My name is Devin Kehl from Cedars-Sinai Medical Center. Myself and colleagues investigated how atrial fibrillation influences right atrial pressure estimation by handheld ultrasound assessment of the vena cava. Now, as a bit of background, ultrasound assessment of the vena cava is one of the many methods we can use to assess volume status and filling pressures, particularly in patients with heart failure. And handheld ultrasound represents a very attractive way to make these diagnostic measurements at the point of care. Now, estimation of right atrial pressure by assessment of the inferior vena cava, or the IVC, is done with measurement of two parameters: the diameter of the IVC and its collapsibility with inspiration. And these two parameters form guideline recommendations in terms of non-invasive assessment of right atrial pressure estimation. However, these recommendations are based on data that does not include patients with atrial fibrillation for the most part. So what we set out to do was to investigate the effect of atrial fibrillation on IVC measurements of the vena cava as performed with handheld ultrasound. And what we found is that the size of the IVC as measured by handheld ultrasound is significantly larger in the presence of atrial fibrillation as compared to sinus rhythm. And additionally, the collapsibility upon inspiration of the IVC is significantly less likely to be seen in the presence of atrial fibrillation as opposed to sinus rhythm. The way we designed this study was to perform IVC measurements in patients undergoing cardioversion for atrial fibrillation, and so therefore we're able to get measurements in the same patients in real time as they converted from atrial fibrillation to sinus rhythm. And interestingly, our estimates of right atrial pressure as determined by guidelines based on the IVC size and collapsibility, based on the new measurements obtained while in sinus rhythm, almost 50% of patients were reclassified into a different classification of right atrial pressure following conversion to sinus rhythm, again in the same patients. So possible interpretations of this data are, number one, that perhaps atrial fibrillation is a confounder that we need to start becoming more aware of when we're making right atrial pressure estimates by ultrasound. And additionally, that perhaps there is a difference in filling pressures that happens immediately following conversion to sinus rhythm, in which case we've been able to demonstrate that handheld ultrasound can pick up on these real-time changes in hemodynamics, which is a very exciting thought. Now in the future, we will continue to use these methods and this technology to study whether the change in IVC size that we have observed between atrial fibrillation and sinus rhythm can be used as a predictor of recurrence of atrial fibrillation following cardioversion. So that's part of what, some ongoing efforts as part of the same project. So I hope this sparks some interest, and hope that handheld ultrasound will be something that will become more widely accepted and as a ways to gauge filling pressures at the bedside in real time.